Opioid overdoses accounted for more than 72,000 deaths in 2017. An estimated 40% of opioid overdose deaths involved a prescription. Our opioid crisis, tonight on Call with the Prairie Doc. Good evening, and welcome to On Call with the Prairie Doc. Opioids seemed like a great thing when they first appeared as a prescription painkiller. Tragically now, they have become a deadly addiction for many. First, let's take a look at this week's Prairie Doc Quiz question. When a person outside the hospital is found comatose, won't wake up, the ambulance crew might, number one, provide naloxone, also known as Narcan. 2, check oxygen levels. 3, check a blood sugar. 4, check for signs of head trauma. 5, check an alcohol level. 6, all of the above. We will announce the answer at the end of the show. Joining us tonight are Dr. Stephen Tamang with the Regional Health and representing Project Recovery, and Dr. Mark Harlow with Regional Health Urgent Care. Welcome, gentlemen.
Thank you.
Thank you.
Appreciate you being here tonight. So let's start with you, young whippersnapper. Stephen, you look like a young guy who's just finishing high school, but you're a family physician. Tell us a little bit about your story.
Oh, thank you. Real simple. I started working with Regional Health about 5 years or so ago as a family physician. And as the practice evolved, got involved in more social issues that I felt were important, and opioids being the problem that they are today, landed at the top of that issue.
Yeah. And so part of what you've done was beginning to treat them, and then you went on to develop a program through Regional Health.
So it's a complicated process to treat the opioid use disorder because it's marred with regulations and it's in large extent a political issue, despite the fact that a lot of people are dying from a very organic disease that we can treat through evidence-based medicine and standards of care. I became aware of that really through continuing medical education. The American Academy of Family Physicians particularly really put a lot of information out about how family physicians should be treating the opioid crisis. Here in Rapid and really around West River, those evidence-based practices just weren't being done, and for a whole variety of reasons. But as I became more and more involved with it and started to see some really amazing outcomes, I got a lot of fulfillment out of it. Went through the process of developing those treatment protocols and ultimately forming Project Recovery, an independent entity with Regional Health's blessing that is now doing medication-assisted treatment here in Rapid and through telemedicine across the state.
Wow. Project Recovery. We'll get back to that. Now, Mark, I know you're an orthopedic surgeon, and the last time you were on the show, we talked about your life as a football player, and then as you went on and became an orthopedic surgeon, and you were involved with helping the homeless, and then the next thing I know, you and I were talking about something, and you talked about the projects that you were working, the Project Recovery story. So how did you get involved?
Well, Steve and I came to be friends and work together through Cornerstone Homeless Mission here in town. And having volunteered there for many years, it really struck me one day that homelessness and substance abuse are often together. Not always, but commonly. And it also occurred to me that unless we treat them both, we will effectively treat neither. So we need to address the homelessness component, and we also need to address the substance abuse component, because if we don't, then the recidivism is at a very high level.
What is recidivism?
Meaning it will recur. If we don't treat the alcoholism or the opioid use or the meth abuse, then they will remain homeless. We'll put them in housing, and they will fail out of that if we don't address the substance abuse. Right. I know we're going to get to this too, but the medication-assisted treatment and the counseling that goes with it is a big part of what I think our future holds. And at Cornerstone, the 12-step programs that we try to implement, the Alcoholics Anonymous, Narcotics Anonymous, Gamblers Anonymous, all of these 12-step programs has as a common thread an element of accountability. And that's one of our emphasis points down there too, is that they're accountable to their sponsors, accountable to others that are trying to help them through their recovery journey.
Right. Well, we know that there's an epidemic, but, and we've said 72,000 died in 2017. What's it doing, and why in the world do we have an epidemic? And what brought us to this spot?
Well, I think it's multifactorial. And in hindsight, you can look at a couple of factors that are obvious. During the 90s, there were numerous pharmaceutical research trials that demonstrated opioids were effective for pain management and they weren't addicting. Now, we know now that that's not a valid conclusion. We also had an FDA.
That was a study done by the pharmaceutical
Multiple
industry.
studies by the pharmaceutical industry.
Gee, I wonder.
But it's not entirely their fault. The FDA also approved opioid meds for chronic pain. So you had physicians that had data indicating that it was safe to prescribe, and you had an FDA that made it
Readily
available and evidence-based. So that created a dangerous situation. And then on top of that, you also had certain regulatory organizations that created pain as a vital sign. And if you didn't address that pain, the quality metrics of a practice were marked down. So that really created a storm where opioids were prescribed at a very high level. And by the way, when you look at the studies, the scoring on the patients said they weren't getting addicted to it. The patients said it relieved their pain. And we know now they're getting addicted to a narcotic, and that's why they had a lot of these subjective symptoms. So it's not so much the inherent nature of the research was poorly designed or corrupt, it was that the outcome was misread from an effective treatment versus getting addicted to a substance that mirrored solving problems.
You know, I'm a case in point because I had a Whipple surgery a couple of years ago where they cut out half my GI tract and half my guts. I mean, it was a significant surgery. And in recovery, the answer was the opioids, right? So as the time stretched on, I had misery, opioid help, misery, opioid help. I'm out a month and a half, and I'm miserable. And the only thing that seemed to help was the opioids. And when I got off of the opioids, part of the discomfort I was having was coming off of the opioid that I'd taken the day before. You know, it's not, and they're not necessarily very helpful for pain. I mean, that's why they've added Tylenol to much of it, because Tylenol, a real and effective pain reliever, is added, and so, gee, you know, this does work well.
There are studies all over the country now that demonstrate post-surgical, post-injury, broken bones versus anti-inflammatories and Tylenol versus narcotics in the opioid-naive population. They have not found opioids to be a superior product in virtually any study. Meta-analysis on the topic demonstrate the same thing. Evidence is clear that for most incidences, opioids are not the right choice. Now, in some cases they are. You know, you have some patients that have severely debilitating situations, chronic issues that, you know, a clinician needs to look at carefully. But we can all agree, and physicians universally agree, opioids are massively overprescribed. Less so now than just a year ago, but still massively overprescribed.
You know, the next major surgery I had was a resection of my liver. They opened me up in the same lines that I had cut on my belly before. And after they pulled the epidural, I said, no more narcotics, I'm gonna go Tylenol. Tylenol works. It just works. When you don't have a lot of pain or for chronic pain, nothing works much. But Tylenol really does help. So my comment is, we've got to address this pain thing and understand how ineffective narcotics or how temporary they should be, because you have to build up the doses to keep it the same effectiveness. It's a tough deal.
We are, and we are getting better at understanding the science of pain and the pathophysiology of pain. Not all pain is the same. Some pain is central and some is neurogenic, nociceptive. There are many subcategories of pain. And to your point earlier, that the standard of care for many years for certain diseases was opioid prescription, but now we know it's ineffective because we've looked back and used scientific methodology to see if this really was making a difference, and in fact, It hasn't. For years, the standard was for back pain was to prescribe opioids and bed rest. Now, it's not opioids and it's not bed rest. So what we thought we knew then, we do know better now if we pay attention, and that speaks to the inexactitude of the science we practice.
As an old doctor, I know how preconceived ideas have not always borne out, you know. So this is an epidemic. There's more to the epidemic, though, than just the narcotic addictive potential isn't there. I mean, people were started on the prescriptions, like 80% of all addicts were initially treated with a prescription, and now they're into illegal fentanyl and heroin and so on and so forth. Am I right on that?
Yes.
Yeah, I think you can break the population into a couple different categories. There's what I think most people break it into is sort of a criminal element and a non-criminal element. There are plenty of patients out there that have never broken a law in their life who are full-blown opioid addicts that unfortunately, if you give someone an opioid addiction and you let them loose and you take away their opioid, that often converts them into a desperation, which can lead to heroin abuse, which is unthinkable to them and their families, but it happens. Or a prescription drug-seeking behavior, which happens all the time. And then you have a population that truly has criminal elements that perhaps grew up in a situation where they developed these, these sorts of addictions, and those are a different population, but treated in a similar fashion because they have the same organic addiction.
Right. Well, we will get back into the causes of an epidemic right after this. But what happens starts as a coping method for a difficult life. It can bring a person down a dark, dark hole. But there are ways to come back into the sunshine.
Now it's been since March 9th, 2016, since I've been high. So it's like 42, 43 months. And then I did cocaine when I was 18, and then shortly after that, I did methamphetamines. And I knew I was in love, and I knew that I would be addicted. I knew I'd be an addict. I was more of a functioning addict. I went to work. At times, I had 3 jobs. I raised my babies alone. And yes, I used while I raised my kids, but I went to work every day. It kind of gave me power and made me, I don't know, of course not sleep. You could get a lot done when you have 24 hours in a day. It got to the point I'd be up for 4 days and down for 4 hours. It didn't get real bad until my kids went to college. And I always said I was going to conquer the world when they went to college. I was going to quit my job at 30 years and conquer the world, and instead the world conquered me. The kids went off and quit my job and didn't have anything to do, really. And so the next year I went on a binge. And once I got in trouble in 2011, then I started shooting up. I'd never shot up before. I knew that would be the end of me. But I started shooting up because then I didn't have to have it on me. And I didn't shoot it up myself. Somebody else did it for me because I knew if I did, I would probably die. When you start shooting up, everything changes. I stopped being a functioning addict. You know, my life evolved around drugs. I went to jail, and that didn't stop. You know, I got out and I'd fail UA, I'd go to jail, caught another charge, and they sent me to prison. And that didn't stop me either. But that's part of my story now. I used to be afraid of saying, or ashamed of being in prison, but I wasn't there long. But it was enough to know I never wanted to go back. But I got out, and three days later, I was high again. You know, it's not about that. It's about having people love you through your mess. And that's when I got involved with the intensive meth program, which still wasn't quite enough. And then it was the drug court in Brookings, South Dakota, that, to me, saved my life. I spent a good year, total time, away from my home, away from my family. I just got really sick and tired of being in jail, of being in a courtroom. I just got sick and tired of calling my boys, telling them, guess what, I'm in jail. Calling my mother, disappointing my mother. But because of the drug court teaching us different ways to live, I'm okay with everything. I've got a good job. Now I just got back from a vacation in the Black Hills, and they went with. I go to work and I want to come home and be with my dogs. And you would never have caught me sitting on my couch watching TV. And today, I love doing that. Or working in my garden, or being with friends, go to church. Sometimes my life can be boring, but that's better than being in jail.
That was an amazing story of a woman who has recovered and lived covering up her addiction. I mean, do we see that much?
Oh yes, there are many functional heroin users in this city. There are many functional opioid users, prescription pain, and it affects every level of life, all the way up to the highest functioning professionals. And by the way, if you're interested in that, just Google people that are addicted to opioids, famous people addicted to opioids, and you'll see an incredible list of folks that performed at the highest level on multiple arenas, not just locally, of course, on drugs.
Right. Any comment about that, Mark?
I think that the point that Steve made earlier illustrates that it becomes their normal. It becomes their new normal. The difficulty is when you can't afford them, and then you devolve into the street life and street drugs, and then it leads to the hepatitis and other issues that are even more concerning. But when you are a capable, high-functioning professional, you can afford to get the medications.
Wow. So this is an epidemic, and I don't sense, I mean, back in the 80s when I was first starting to practice and you weren't born yet, I don't remember any epidemic of narcotic abuse. I just was very reluctant to prescribe medications for very long. And, you know, and those kinds of patients either left my practice or tapered off of the drugs. And that's how it worked. So, you know, sometimes people have chronic pain syndrome, for example, that is in particular not very well treated with opioids. Let's talk to that. Chronic pain syndrome, what the hell is that, Mark?
I think of it as an alarm clock that has a snooze button that never turns off. The alarm rings and you reach over to turn it off and it won't turn off. The pain response just is a never-ending circle, so you can't ever turn it off. And so the sympathetic blockades and other things that have evolved, again, as we've advanced our science of understanding the pathophysiology of pain, has really helped us treat that. But that's been around since the Civil War. First described in Civil War, described then as causalgia. We still don't have a great handle on it. Pain, to me, is one of the great unknowns in medicine, because so much of it, when you say that pain is in your head, you're not wrong.
It is all in our head.
It is, yes.
The nerves all come up and it settles into the brain. The brain says, this is how I interpret it. And here's what I'm going to do. For acute pain, narcotics are fabulous. I mean, obstruction of a smooth muscle tube, man, that's it. I mean, it stops the peristalsis, the toothpaste squeezing, and takes away that horrible wrenching pain that people have acutely with abdominal type illnesses, you know, gallbladder disease, appendicitis, you know, obstructive intestinal problems.
And for broken bones, it's our standard too. That hurts a lot when you break bone or have lacerations. And because of the physiology of healing of bone, we don't like to give anti-inflammatory medicine for the first several days, because the first stage of healing is inflammation.
Right, it's necessary.
So we'll rely on the opioids for that. We know that hurts.
And I'm a hospice director. We depend like crazy on fentanyl, the bad name. The fentanyl patch is like a blessing, a wonderful way to help people on the end of their lives. So there's reason for this opioid kind of medication. However, for chronic pain, it's another story. So what's your take on chronic pain, Stephen?
Well, chronic pain's a real thing, obviously, and there has to be better ways to deal with it. I think when you put treatment for the opioid use disorder in perspective, and chronic pain in particular, it falls into the prevention piece. Like, you want to treat people with chronic pain the most appropriate way possible while preventing them from becoming addicted to narcotics. And so That comes down to education, both for the patient, continuing medical education for the providers, and trying to figure out what works. For example, instead of narcotics, muscle relaxers or anti-inflammatories, Tylenol, or nerve pain modulators like gabapentin or Lyrica, things that are probably going to be more helpful to them need to be pushed, and narcotics, the line needs to be drawn. So really, from my point of view, in the line, in the scope of the patients I see, it falls into prevention. You want to take care of the chronic pain. You don't want them to fall into opioid use disorder.
I think about the person who has a knee surgery, and initially, some surgeons would put people into a constant moving machine because they don't want to move it.
Right.
And what happens sometimes, they don't tolerate it, they won't move it, and then they won't move it, and then time goes by and they won't move it, and then when they move it at all, it hurts like all get out, and then they never get out of a chronic pain cycle. You've got to get rehabilitation, and movement is 9/10 of the story. Am I right?
You're correct. And in fact, a certain subset of patients require a manipulation under anesthesia later if that stiffness becomes a problem, because if you allow that stiffness to persist, it will scar down in that position and you'll never have normal function out of that knee. So it's imperative to get the motion, and that means handling the pain. If you could turn the pain off, they could bend their knee freely while they're still on the operating table.
Right.
But it's the pain that inhibits that. So we need to find that balance between what is too much and what is just right.
Right, and acutely, it can be an opioid, but chronically, it needs to be movement.
Yes.
It's rehabilitation.
Right.
There are other non-medicinal therapies for chronic pain, though, is there not? Such as music, and let's go beyond the scope of our classic approaches. How about the acupuncture, manipulation, massage?
Biofeedback, all kinds of different modalities. And I'm a firm believer in doing what works. So if a patient comes to me and says, I really benefit from acupuncture or acupressure, I may not understand the science of it, but if they say they're better because of it,
Let's
then
do it.
I'm all in, because that's what matters to me the most, is that they be better. If they came and said, what have you heard about magnets? And I have no science to explain why magnets would work to help an arthritic knee or hip. But if they say they feel better by virtue of putting magnets on, I encourage them to do it. My end goal is to make them feel better. What Steve often refers to as harm reduction. If we can cut down on the disease process and make people feel better, then that's a win.
Right. So, any particular other comments about chronic pain, Stephen?
I think it's important that it's a multidisciplinary approach. Oftentimes, that's the key element that's lacking. So having a physical therapist on board, having a psychologist sometimes on board. It's hard to deal with chronic pain. It's a psychological stressor in addition to a physical element. Having a good primary care doctor, and if necessary, orthopedics or specialists. And so I think chronic pain needs to be taken on as a team approach. It needs to be taken seriously by all parties, and you'll get a lot further.
And I agree. And Steve has taught me this, is that medication-assisted treatment for opioid use disorder is made so much better if you add counseling, because now you're addressing both the physiology and the psychology of the disease of addiction. And working together, they're far more effective.
One talks about depression in the person with chronic pain, and you don't know which is the chicken and which is the egg. That maybe depression was part of the problem for the first, for the need for the surgery in the first place, and then the subsequent result is the depression. The pain doesn't go away, the depression gets worse, and the depression worsens the chronic pain. So oftentimes an antidepressant can be helpful too.
Absolutely.
So I wanted to talk a little bit about naloxone, or Narcan, the reversal agent, which is an old drug. You can get it in an underserved country for 50 cents to $6 to make for the ingredients.
Right.
And the anesthetist or anesthesiologist can use it and inject it, and it's $20 or something along the line. You can get in Narcan dual pen for $4,000. And I would ask, what happened there?
Well, I think if you look at the price points on it, the nasal spray is quite a bit more reasonable. My last understanding was it was in the range of $100 to $200. So,
Right.
so those are available, and I suppose that goes into the regulation process and all the hoops that the companies have to go through. But it's a critical tool. We should have access to it because it saves lives.
For this 50 cents to $6 ingredient, they're going to drop the $4,000 all the way down to something like $300 because we really need this, right, in this epidemic, and they got us over the barrel. It just makes me incredibly angry.
Epinephrine is the same. The EpiPens for people who are sensitive to bee venom, who can die from a bee sting, that they also had to pay thousands of dollars for an EpiPen, which was really about $5 worth of epinephrine in an injector. Same principle. And it was wrong then, and I think it's wrong here. Narcan saves lives, we know that. Police carry it, paramedics carry it, families of people who are addicted to narcotics often carry it because it can save lives. And we know from our own experiences that it is a profoundly effective reversal agent, almost immediate in its effect, very successful, and it has no side effects. Its only effect is to block the receptors and displace the opioids that are causing the respiratory suppression, which can be fatal.
It seems to me, and I might not be speaking in turn here, but it seems to me that a legislative action should be called for at a time like this. But I'm not going to make that call. I'm just going to make a sort of a subtle opinion. Well, what can we do now, really? Let's talk about what you're doing at your Project Recovery. What is happening that you can do to help people who are caught in the grips of this medication, this opioid overdose, opioid problem?
Project Recovery is our best attempt at the ideal state to attack the opioid epidemic. And the principles are evidence-based medicine and highly accessible. So when we started on a very small scale, and simply because we wanted to be, we grew it, and there was no one else around doing it, and we encountered some support from the community. Addiction Recovery Center of the Black Hills and Doug Austin was a big believer in it, and then regional supported us in our endeavors. And as we started, we found support. The state, with the Division of Behavioral Health, was really the organization that recognized we were following evidence-based medicine and to get started with the process. So what we have right now is a no barrier entry policy. So it doesn't matter if patients have the financial means, it doesn't matter if they're insured. The only barrier to access is an ID card. That's it. They can come in, we give them the most evidence-based medicine that is available, and those are guidelines that are done through numerous organizations. SAMHSA is the biggest producer of evidence-based guidelines when it comes to medication-assisted treatment. And then we have partners that deal with both the counseling that Mark alluded to before, we have mental health allies, and then we try to use the power of the health system with regional health to cure hepatitis C, to get primary care where is needed, et cetera. So it's a growing process, but that's the basics.
I think about the whole issue of trying to bring them back, and that you have an open door, whether they have money or not, whether they've been referred to you or not. They can be self-referred to you.
Absolutely. Well, these patients are often in crisis, and they are many times self-destructive behavior. And so it's really important that when they crystallize the idea to try to seek help, they're going to find a non-judgmental environment, and that they're going to find a clinic that's based on the philosophy of harm reduction. For example, if you're an IV heroin user and you come in having used IV heroin, we're going to try to influence you down the spectrum, even if that is, hey, I'm only going to smoke heroin. That's still something that we do not approve of, but we're going to count that as a win. The medications for opioid use disorder are in of themselves opioids. You've heard of methadone, I'm sure. Mm-hmm. By the way, there's much safer medications than methadone. Methadone is kind of a dying drug, and we're trying to stay away from it. But the point is, you move them down the road. We reduce harm, and the evidence is really clear. You take that approach, you get way further with these folks than if you try to implement some paternalistic, high consequence. Yeah, contract or high consequence, like, oh, I relapsed, so therefore you're kicked off the program. That never happens. If you relapse, we're gonna feel sympathy for this person. We're gonna try to help them, give them whatever tool we can, And they know that. They recognize that. And so when they make a mistake and they come back, we continue on. And by the way, one of the big differences when they see us, they see a provider. They see a physician or a PA or nurse practitioner. So their plan is individualized, depending on whether they should go on to replacement medicine or not, whether they need an antidepressant, whether they need more of a medical workup. And so they get that entire service for free. And then we arrange an appropriate follow-up and work with them the best we can to get the outcome we're looking for.
And the word is getting out in terms of self-referral. In the last 2 months, I've had 2 phone calls, numbers I didn't recognize, and I rarely answer my phone if I don't recognize the number on the caller ID, but on both occasions I answered the phone, and they were men who said they got my name from someone at the homeless mission and my phone number, and they'd heard about Project Recovery. Could I get them in? They both wanted to get off of their opioids. And I said, give me your number. I've got your number. I called Steve, and within a half a day, they were getting their first appointment squared away.
Wow.
That's how quickly it can happen.
Well, let's talk about Project Recovery with this. There is a freestanding clinic for the treatment of substance abuses, especially opioid use disorder in Rapid City and Pine Ridge. Everyone is welcome. Here is more.
Hi, I'm Tim Elward. I'm a PA and the clinical director for Project Recovery. We are super excited about the expansion that we're doing across the state, both with telemedicine and with a burgeoning partnership with Avera Health. One of the key aspects of what we are trying to do is just open the army of physicians who are ready and available to treat with medication-assisted treatment. We're trying to reach all those folks across the state who are struggling with substance use disorder, and that includes opioid use disorder and alcohol use disorder. This is one of our typical exam rooms. There are 4 of them that look very similar to this. As you can see, it opens up to a few chairs. Back this way is where all of our staff is seated. Nursing, administration, providers all sit back here. Another thing we are emphasizing here at Project Recovery is the expansion of our counseling and peer support program. Now that's rolling out really soon with the inclusion of a couple of peer support folks that are starting next week. Their goal is just to be that extra piece of support to our patients who really need it. And they're going to come in super handy in that time of crisis mode, in that time of need, where they can be someone to ask questions of, get support when they need it. Moving this way, this is where we will see all of our counselors and peer support folks. There's 4 different rooms here, an example of which is right here. And this creates a nice, comfortable, safe environment for the patients to meet. We can also have counseling sessions with both providers, peer support, counselors, and the patient. Just want to highlight that medication-assisted treatment is the absolute gold standard for substance use disorder, and we at Project Recovery are committed to that mission, to treating those folks who absolutely need this treatment.
Wow, I mean, I think your Project Recovery is a fabulous program. I mean, I'm just bowled away from this. I would wonder if you're not in Rapid City or Pine Ridge and you have a primary care, if you don't have a primary care doctor, what should someone do to get similar kind of care?
All right, so this is a problem that's been addressed nationwide. You are aware that there are incredible amounts of financials that are being pushed down from the executive branch to SAMHSA to the states to try to get medication-assisted treatment, and it just hasn't penetrated a lot of smaller communities. And the DEA, the people that regulate the medications for those addicted to opioids, have actually put out a number of bulletins reassuring providers that they can legally perform telemedicine for folks that need access. And there's a lot of reluctancy to do that because it's a different way of practicing, but the evidence is there. The legality is there, and so Project Recovery has fully endorsed those DEA recommendations. So right now, if you pick out your phone or go to your computer, go to project-recovery.org, you can make a telemedicine appointment.
Project-recovery.org.
You can make a telemedicine appointment anywhere in the state with us, and typically same day or within 24 hours, 5 days a week, and we will see you. And we can do your assessment and prescribe you medications.
Wow. And my sense is that really the rest of the state of South Dakota, physicians in particular, have endorsed that kind of topic, of course.
Yeah.
South Dakota State Medical Association, tell me about what has been done through that.
For the last 2 years, it has been the strongest point of emphasis for the leadership at SDSMA, the South Dakota State Medical Association, and giving credit where credit is due. The last two presidents, Bob Vandermark and Chris Dietrich, both exceptional physicians and both exceptional leaders, have really taken great pains to move along the education of the medical community in our state to decrease the number of prescriptions of opioids, to decrease the number of pills per prescription, decrease the number of days of prescription, and to focus on using the morphine milli-equivalent scale so that we don't overprescribe and put people in potentially dangerous situations. So the work that the state leadership has done has been exemplary.
Right, and right now, Robert Summerer, a surgeon from Madison, spoke last week. I was there at his meeting.
He's carrying on the work that's been done by his predecessors, and he's also doing an exceptional job of bringing this message to our prescribers. And the statistics that the state keeps have shown that the numbers have been going down steadily. And over a 3-year period, 2016 to 2019, we've had a 30% reduction in opioid prescriptions in this state.
And I think we were low to start with.
We were.
I mean, we're what in the country as far as?
49th.
49th, and that may not be per capita, but per capita we're still really on the low side, right? So hats off to the doctors of the state of South Dakota. We could do better, but we're doing really pretty well.
Working to do better.
And the nurse practitioners and PAs who are involved.
Absolutely. All of the prescribers have bought in.
So you talked about medication for treatment. So there's drugs, buprenorphine and naltrexone that are being used. What are those drugs and how do they work?
So the FDA, after a lot of research, has come out with 3 medications that are approved for treatment of opioid use disorder. Well, treatment for medication-assisted treatment, sorry. The opioid use disorder specific, you can use methadone or buprenorphine. Initially, methadone was used primarily. That is changing. Methadone is in and of itself a narcotic that has very dangerous ceiling effects where you can actually overdose and die on it. Buprenorphine, on the other hand, is very safe. You can, if you took it, someone took it that had no opioid tendencies or resistance to it, if they took it, they might feel a tiny euphoria, but the average drug user feels nothing from it. So you don't get euphoric off it. It's very difficult to overdose on it because there is a low ceiling effect, and it has a profound affinity for the receptor, meaning that it can't be displaced. If you take heroin while you're on buprenorphine, nothing happens. So it's very safe, and it keeps the patients who are just looking to avoid the withdrawal symptoms stable. And that's why it's such a great drug compared to methadone, which does have abuse potential, can be injected IV, and can kill you in overdose situations. So, and the data indicates that buprenorphine is just as effective as methadone in large scale.
Is naltrexone about the same thing?
So naltrexone you can think of as just a long-acting Narcan, and that is useful in 2 circumstances.
The recovery drug.
Exactly.
It's the antidote.
Yep.
Yeah.
It just takes time to act, and it's used not only in folks that want to safeguard against relapse from opioids, but it's also used in alcoholics as a medication-assisted treatment, because when you take naltrexone, it actually has an effect that decreases a person's alcohol consumption as well. And so so it's got a couple of FDA labels that's quite effective.
So, I mean, you know, there is potentially new legislation coming down the pike. What is that all about, Mark?
Well, it's that one of the impediments that we have in all aspects of medicine is the pre-authorization component, where we can't initiate a treatment modality until we get authorization from the person's third-party payer. CMS
Right.
is...
For example, if I want to have a particular drug for my cancer, I need to have my doctor call the insurance company and pre-authorize it, or I might not get coverage.
You might have to pay out of pocket for that if you don't have that pre-authorization. And that's true for therapy and workers' compensation cases. It's true across almost all of the disciplines in medicine. But CMS, we're told, is giving serious consideration to waiving the pre-authorization component. So when the person makes their first appointment to come to Project Recovery, they can begin their treatment that day.
Now, is buprenorphine and naltrexone pretty expensive?
I would say, well, again, wholesale or retail. Wholesale, not so much. Retail, it depends. But the drug companies, and Steve has developed great relationship with them, have been extremely generous to providing the necessary medications at a very reduced cost. And I believe that's true for hepatitis C medication as well.
Absolutely. Let me speak a little more to that because the Division of Behavioral Health deserves immense credit for the fact they pay for these medications for just about anybody that can afford it, and their turnaround time is quick. So the average patient that comes into Project Recovery has no means to pay for medications. Right. And you're right, these medications out of pocket are very expensive. Medicaid pays for it, or if they have no means, then we can typically, I say virtually always, get it paid for by the Division of Behavioral Health if the patient meets financial hardships, which the majority do. If they have insurance, then insurance covers it. And if the patient is affluent, then of course the patient pays for it. But for the most part, it is accessible at all levels. And speaking about this legislation that you brought up, it is an extremely important bill that has been talked about before. It's called the MAT Act of 2019. It was in MAT Act of 2019. MAT Act, yes.
Not the MAD Act.
Not the MAD, MAT. And it was created because right now, imagine this scenario. You've got an epidemic, right? You would agree with that. The opioid epidemic. People are dying at the extent which is hard to imagine. I mean, you put it up there with other pathologies. Just as many people die of this as peak historic rates of motor vehicle accidents. It's right up there with breast cancer. Like, it's a terrible thing. And you have 250,000 primary care doctors in this country, roughly. 5% of them are waived to fight the opioid epidemic with the most evidence-based.
With the best treatment.
With the best treatment. 5% is waived. You've got 95% of your army on the sidelines.
Without guns or without weapons.
Without any way to treat it. The 95% aren't super interested in getting involved, not because of the 8-hour course or the 30-hour requirement of education. It's the arduous work that goes into tracking your prescriptions because, you know, they put in arbitrary limits. I can prescribe, as a physician, a tremendous amount of narcotics. As soon as I got my DEA license,
you can write out a prescription
for as much as you want. But if you're trying to treat somebody that has opioid use disorder, they limit you to 30 patients. They limit you to rigorous bookkeeping to make sure you don't have more than 30 active scripts out if people are falling off and coming on. They make you go through particular processes in which you have to go, sign through these various forms and background checks.
And who is they?
Legislation, federal government, I suppose. Yeah.
Drug Enforcement Agency.
Yeah, and there is a number of reasons for that. But this new legislation aims to abolish the waiver system, abolish the bookkeeping, let the primary care physicians get into the fight. I couldn't be more excited about it. The people that oppose it are the ones that have methadone clinics across the country that arguably, I've grown not to be particularly receptive to their opinion because I think they're wrong. They argue that their way, the methadone clinic approach, is the correct way. This legislation argues the counter, and I agree with that. You unleash the army of 250,000 primary care doctors, such as France did in the late 90s, you'll see a massive drop in opioid deaths, and that's what this legislation represents.
Wow. Well, I mean, I was a methadone prescriber for a long period of time, and there was, you can overdose on it. It sneaks up on you. People get too high of a dose. They can share it with their buddies. It's not a good drug, and it's dangerous, and we change our minds on these things.
I want to go a little deeper into this if I can. The way that medication-assisted treatment has been done across the country. Real quickly. Okay. So the way it works on an MAT clinic, on a lot of MAT clinics that are methadone-based, the patient comes into these clinics. They're not seen by a provider, a physician. Many of them are dosed by a nurse based on a protocol. And with that dose comes strings of numerous, very arduous sessions of intensive counseling that is reimbursed at the state level. So the patients are being held, you've ever heard the term liquid handcuffs? Patients are being held multiple times in liquid handcuffs, which is related to their methadone dosing, and are forced, if they want to stay in the program, to continue through counseling, excessive counseling in multiple cases, to stay in the program. Opposite of evidence-based medicine.
All right. So after this short break, please stay tuned for the important takeaway messages from our guests, as well as the answer to tonight's Prairie Doc Quiz question.
Our studio audience controls the direction of our discussion. They step up to the mic for an Ask Anything about an assortment of healthcare issues. Next time, On Call with the Prairie Doc.
All of us want our family, neighbors, and friends to have the ability to make appropriate decisions about their health care. To do so, they need access to information from reliable sources like Dr. Holm and his guest physicians. Hello, I'm Stephanie Herseth-Sandlin, and I serve on the volunteer board of directors of the Healing Words Foundation, a 501c3 organization established to support the work of the Prairie Docs. With your charitable donation, you can help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. This mission is so very important to rural communities and residents in particular across South Dakota and neighboring states. Please consider a personal or corporate gift. Just go to prairiedoc.org to find more information on how you can help. Thank you.
Welcome back. So Mark, what are the most important points you think we should make in the next 15, 30 seconds?
I think the key to our success is recognizing that addiction is a disease, that its causes are multifactorial and therefore its treatment is multidisciplinary. And so by combining medication-assisted treatment with counseling, we have a good chance of addressing this as a medical community. And I would like to say that I'm proud to know Steve, and he's been an exemplary leader for this program here in our state.
Thanks for that point, Mark. So Stephen, final points that you'd like to make.
I think we're in the middle of a war against the opioid epidemic, and I think we need to unleash the army of physicians that I know would do an amazing job and take care of these patients the way we take care of any other chronic disease. I think the legislative pushes that are happening are going to be key to that, and I think continuing to bash away at stigmas about these patients and employing the highest degree of evidence-based care is paramount to our success.
Well, we appreciate your help and your efforts in these regards, and yours too, Mark.
Thank you.
And now for the answer to tonight's Prairie Doc Quiz question. When a person outside the hospital is found comatose, won't wake up, the ambulance crew might, number one, provide naloxone or Narcan, 2, check oxygen levels, 3, check a blood sugar level, 4, check signs for head trauma, 5, check an alcohol level, 6, all of the above. And the answer is?
All of the above.
All of the above. We'll be right back after this.
For nearly 2 decades, the Prairie Doc organization has endeavored to enhance health and diminish suffering by providing useful information based on honest science in a respectful and compassionate manner. Health professionals volunteer to answer your questions each week, creating a vast Prairie Doc library of medical information available to you and your family 24 hours a day. Make sure you don't miss a thing. Follow the Prairie Doc on Facebook and YouTube for free and easy access to the entire Prairie Doc library.
My patient was in severe pain, suffering from an obstruction in his gastrointestinal tract as a result of spreading cancer. I knew that morphine, one of the opioids, would provide immediate and merciful relief, and it did. We are thankful that we have something that can palliate pain and provide comfort for severe, acute pain, especially for patients at the end of their lives. That's good. In contrast to the good that opiates can do for certain acute pain, we know they are not very effective for musculoskeletal or neuropathic pain, and fail terribly in helping long-term pain and chronic pain syndrome. Despite this inadequacy, opioids are still being overprescribed for most post-operative musculoskeletal pain. Also, our bodies quickly develop tolerance to opioids, thus continually requiring increased doses to get the same effect. In addition, withdrawal symptoms from opioids can be significant, making it difficult to stop taking opioids once hooked. It's estimated that about 75% of those taking illicit opioids got started from a prescription. More than 100,000 people are regularly using heroin, and about 12 million people are taking non-prescribed illicit opioids. That's bad. It gets worse. Opioids have an insidious potential for overdose, which depresses the drive to breathe so much as to suffocate people to death. In the U.S., it's estimated that about 70,000 people die each year from opioid overdose. In comparison, 83,000 die from diabetes, 56,000 from influenza and pneumonia, 47,000 from suicide, and 40,000 from motor vehicle crashes. That's very bad. Ultimately, care providers need to prescribe opioids very judiciously, and people must be careful when taking prescribed opioids, and people need to avoid dangerous illicit forms. We do have an antidote to opioid overdose called naloxone or Narcan. If given soon enough, it displaces the opioid from the brain pain receptor, and the victim starts breathing again. Thus, every ambulance and emergency room has multiple doses of this life-saving reversal agent readily available. Unfortunately, in response to this opioid epidemic, the drug manufacturer of naloxone, which costs 50 cents to $6 to make, raised its price to up to $4,000 for one dual pen auto-injector. Fortunately, a generic version will be available soon with a 2-pack of auto-injectors for only $180. Until then, we pay the higher price. That's ugly. Bottom line, if we hope to find help for this crisis, we need to understand the good, the bad, and the ugly about opioids. A big thank you to our guests tonight, Mark and Stephen, for joining us in the Rapid City studio of South Dakota Public Broadcasting. And thank you also to SDPB for sharing their beautiful West River offices and the great staff here at the studio who have helped us produce our program tonight. If you'd like more information about this program or to see more episodes, please like and follow us on Facebook or visit us at prairiedoc.org. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Urology Specialists, Brown Clinic, American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians, Black Hills Medical Society, Aberdeen District Medical Society, Brookings Madison Flandreau District Medical Society, Sioux Falls District Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Aberdeen Asthma and Allergy, and Swiftel Communications.